welcome back. We are joined today by our favorite diabetologist, Dr. Amber Healy. And that is not to be offensive to the other diabetologists out there, but we really like Amber Healy. So today we are going to talk about everyone's favorite topic at the beginning of the new year, the ADA Standards of Care 2025. So the topic for this particular video, we are going to talk today about Chapter 13 in the ADA Standards of Care and diabetes care in older adults. So Amber Healy, where should we start in there? I think you and I might have talked about a particular table that maybe where we're going to start.
Yeah, so, a lot of these chapters, they kind of go together, they tie in, and there's other places you can find your framework and then get into details. Yeah. So actually in Chapter 6, where they talk about glycemic goals and hypoglycemia, there's a really great figure, 6.2. And what that really focuses on is individualizing the hemoglobin A1C target to the person.
Nice.
And that becomes really important with older adults because older adults vary in their functionality, their comorbid conditions, different considerations, things that matter to them. So like they have a great framework in that chapter, but I would like to draw your attention first to just looking at what you consider when you individualize those targets because they tie together.
That's perfect. And actually that will go right into our next discussion because we're talking about what matters for that individual. And so moving on to Chapter 13, which is the chapter on older adults, we wanted to talk today about the 4 M's framework. And I know that is a figure table 13.1. So what can you tell me about this? So the 4 M's, what can you tell me about the 4 M's?
So it's the framework of, where we approach a patient. So what's their mentation? Are they able to remember to take their medications? Do they have underlying dementia?
Great.
And if you're not completely sure, they do recommend neurocognitive evaluation at age 65 and older. Nice. At initial visits, as needed, at the when you feel like it may be warranted.
Okay.
If there's been a change. You also, making sure, does the patient have any anxiety, depression, diabetes distress that you need to be aware of?
Okay.
And when it comes to their own coping skills with their self-care and even their ability to utilize technology, which I know we can talk about a little bit more.
Okay, that's great.
And they also then, mobility, that's important because, if you've got issues with dexterity, that determines what you do for a patient. If you have issues with vision and hearing or,
absolutely,
leg function, foot deformities, the comorbid condition that we see, diabetes of neuropathy. So all of these are things we need to consider when we're looking at the whole patient.
Awesome. So we have mentation, mobility. What's next now?
Medications. So
what?
I know, you love drugs.
Did somebody say medication?
I did say medication. And so things to consider, what is the patient's treatment burden, like the polypharmacy. We have to think about how many pills are they taking? Can they take an injection? Do they have a history of adverse reactions to other medications?
Absolutely.
Can they afford it? Yeah. A lot of the meds that we now recommend are hard to get because they have really high copays.
Yes, absolutely.
And then what is their social and family support?
Okay.
Are they at home with somebody? Do they have a really engaged caregiver? Are they in a long-term care facility where they have people that keep an eye on things? And how complex should this medication regimen be just for this one condition in the context of everything else that they deal with in a day? And then we have to worry about hypoglycemia.
Absolutely.
Because hypoglycemia can precipitate a fall.
Absolutely.
And falls lead to broken bones. And that can completely change the trajectory of a patient's life.
Yeah, absolutely. So we've done mentation, mobility, medications.
And the fourth one is what matters. So matters, or the fourth M.
Matters.
So what are the individual and even the family sometimes, what is the goal and the expectations?
I love that.
What symptoms on medications, like, if they're on medication with a specific side effect, what's a quality of life issue for them?
Yeah.
What's not a quality of life issue for them?
That's huge.
When it comes to their eating patterns, even, like, there are some people, they're not giving up something. They're not giving up their pop. They're not giving up their cookies. Like, where you have to meet them where they are with their, what their expectations are. And when you're considering this 4M framework, you even have to think about life expectancy. It's not a fun question to ask sometimes.
Right. So going back to mentation, we're going to talk a little bit about technology. And if you hear any beeping or shaking, that is not my brain. That is actually construction going on outside. So don't be alarmed. Don't be alarmed, Dr. Healy.
Okay.
It's not in my brain.
And it's not a CGM alarm.
It's not an alarm.
Okay.
No, not a CGM. But since we're talking about CGMs and beeping, let's talk more about technology.
So, a lot of times people think older adults aren't tech savvy.
Yeah.
But, there have been studies that have been done in older adults to look at how they do a technology, and actually the recommendations are that you offer it to them.
That's cool.
If the patient's comfortable, they're interested, they have either the desire themselves or the support from their family.
That's awesome.
To utilize technology, it's actually recommended to recommend CGMs, and then when it's appropriate for some of our type 1 older adults, like insulin pumps and smart pens should definitely be considered if they're game for it.
I think that's exciting. I think that's awesome. Let's talk a little bit more about that too, because we know about with our older adults, sometimes what their coverage, their insurance coverage looks like. And so for people who do not have Medicaid, for the people who are on other types of insurance, tell me more about a little bit about coverage for those and what you've seen, what needs to happen for people to be able to get those CGMs.
Yeah, so for Medicare, we talked about this, I know, in another session.
Yeah.
And a lot of them are on Medicare. So we're still mostly going through Parachute, that third-party software to determine who the durable medical equipment supplier is.
Okay. Great.
And in order to qualify on Medicare for a CGM, the patient needs to be taking at least 1 injection of insulin a day.
Okay.
And so in your type 1 patients, that's not a big deal because they're insulin dependent. But when we look at our type 2 folks who we've really been gearing our series toward, as long as they're taking a once daily long-acting insulin, they should qualify for the use of a CGM.
Cool. So when we talk about our older adults, we wanted to reiterate that table 6.2 where we started about treatment. We also discussed the 4 M's, which are found in this figure 13.1.
Yeah.
Talked a little bit about technology and mentation in the older adult and the coverage of those CGMs. Yeah. So is there anything else you'd like to add before we end this session? I
think medications are a really important part of this, those 4 M's. There's considerations you need to make. Like we said, if they've got an end organ disease or a complication, you need to think about, what meds could make that worse?
Absolutely.
What medications could actually be a benefit? So, as we continue to work on cardio, renal, metabolic, the whole picture.
Perfect.
We look at SGLT2 inhibitors as an example because they have indications in heart failure now. You can use that all the way down to a GFR of 20, and we know a lot of older adults have heart failure. They have kidney failure. Or kidney disease. Not failure. Diabetes associated kidney disease. So, thinking about that, but, if they have a lot of urinary tract infections, you kind of or yeast infections, you kind of have to weigh the pros and the cons and look at that, what matters most to the patient, what affects their quality of life, as you try to help with that. We know metformin, if your renal function is dropped, your GFR is below 30, we should stop it. We know with, pioglitazone. That if the patient has osteoporosis or they have heart failure and swelling, probably not a great choice for them. And the other thing, when we worry about mobility, we talked about frailty a little bit and sarcopenia. Well, recently there's been more concern with the GLP-1s and what part of the weight are they losing? They still don't actually know the answer to that, but
Right.
is that the best choice in a patient? And then if somebody's got decreased appetite already and you don't want to promote malnutrition,
Right.
GLP-1, like if it further hampers their appetite,
Yeah.
it may not be a great choice for them either. So there's a lot of different things you have to look at when you're picking meds, when you're adding the technology and looking at the whole patient.
Okay. That sounds fantastic. Right. Thank you, Dr. Healy.
Welcome.
Thank you for joining us today as we talked about Chapter 13 in the 2025 ADA Standards of Care, and that's care for our older adults with diabetes. Have a great day.